Hello, everybody. On behalf of Dorothy Thompson, my co-moderator, and myself, Graham Holder, I'd like to welcome you on behalf of SOE to the SOE webinar on electrophysiology. Before we start, I'd like to just run through some housekeeping issues. Audience questions are welcome, and you can answer as many as you wish, ask as many as you wish, but please do so via the Q&A. They will be looked at, and we will try to answer as many audience questions as possible. If you have a particular question when the webinar is finished, then you can email it to the address which you can see on the screen, and we will try to answer them separately, which can then be accessed via the SOE website. The webinar is being recorded, and you can check it out later via the SOE website, and it will be placed on the SOE YouTube channel. In terms of the running order for today, there will be 5 presentations in total, and there will be a short Q&A after each presentation. So please, if you have questions, make sure that you submit the questions during the presentation. Simply submit the question via the Q&A section on Zoom, and it will be regarded and passed to moderators, and then we can ask the questions in the appropriate time. I don't think there's very much that I need to say other than that. We'll be concentrating on structure and function. All of the speakers are experts in their fields, and I think probably we can now start.
So, well, to begin this webinar, I would very much like to welcome the first speaker, Graham Holder, who will provide a brief introduction to electrophysiological testing. For those who don't know, Graham is a professor of ophthalmology in the National University of Singapore, and is one of the most experienced, influential, and eminent world authorities when it comes to clinical visual electrophysiology to the visual system. So it's a great pleasure.
Good evening. We'll start with an introduction to electrophysiological testing. You will be familiar with the anatomy of the visual system and the visual evoked potential, the response to a fluorescent checkerboard or to a luminance stimulus, arises in the occipital cortex, but is non-specific. Arising at the cortical level, it can be affected by anywhere anterior in the visual pathway to the cortex, including the chiasm, the optic nerve, but also the macula, inappropriate refraction, vitreous opacities, etc. Moving to the eye, the electrooculogram measures the interaction between the retinal photoreceptors and the retinal pigment epithelium, and is a measure of the global health of the RPE. The ERG is a masked response of the retina to a luminance stimulus and can be used to separate the function of the cone system from the rod system and from the photoreceptors from the inner nuclear layer. But as a masked response, it is normal if the dysfunction is confined to the macula. To test the macula, we can use either a contrast response, reversing checkerboard, the pattern ERG, which although arising largely in the ganglion cells is driven by the macular photoreceptors, or we can use a luminance response, the multifocal ERG, which enables a spatial distribution of central retinal cone function to be assessed. As a contrast response and a luminance response, the pattern and multifocal ERG provide complementary information. We need electrodes to record the small signals, and these upper 3 electrodes can be used either for pattern ERG or multifocal ERG. The contact lens electrodes shown below cannot be used for pattern ERG as they interfere with the optics of the eye. These are all ERGs in a normal subject under dark adaptation, and they're all different, and is therefore evident that standardization is of fundamental importance to communication between laboratories. Here, note that with a red stimulus under dark adaptation, there's an early component from the cone system, a late component from the rod system. These are the 4 main ERGs mandated by the International Society for Clinical Electrophysiology of Vision. We start off with a dim flash in the Ganzfeld in a dark adapted eye. DA is dark adapted, LA light adapted. 0.01 is a dim flash, 10 is a bright flash. And with a dim flash in a dark adapted eye, we get a response known as a B wave, which arises in the on bipolar cells of the rod system. And arising at an inner retinal level, it gives sensitivity, but not specificity. When we use a bright flash under dark adaptation, we then get the A wave, which is predominantly coming from the rod photoreceptors. There is a small contribution from the cones in this dark adapted response in a normal, but the cones are very small in number compared to the rods, and this is a predominantly rod response. And the B wave continues to arise at an inner nuclear level. So this gives specificity between photoreceptors and inner nuclear layer disease. We then light adapt the patient by turning on the light at the background bowl. That provides a rod suppressing background, and we then flash a light at 30 times a second. The rods can't respond, so this is a cone-driven response giving sensitivity. Specificity is then achieved by a single flash cone ERG with the A wave coming from the photoreceptors and modified by the off bipolar cells, and the B wave a synchronized response from on and off bipolar cell pathways. Analysis takes place of the size, timing of the response. These are reasonably large signals, easy to record, but also the shape of the response. And this is a minimum recommendation, and additional recordings may well be necessary. The pattern ERG is the response of the retina to a reversing checkerboard, and the experimental work of Laura Frischman and our clinical work has shown that the N95 component arises in the retinal ganglion cells. And although about 70% of P50 arises in the ganglion cells, it's driven by the macular photoreceptors. And therefore, if we have macular disease, P50 is affected. But if we have ganglion cell dysfunction, either primary ganglion cell disease or retrograde degeneration to the ganglion cells from primary optic neuropathy, then P50 can be spared and the N95 component shows selective abnormality. The pattern ERG therefore enables accurate interpretation of the pattern VEP. It is important to remember that the pattern ERG is never extinguished by optic nerve disease. This is a sad case of a patient with a very large intracranial meningioma who has a blind left eye. But even in that blind left eye with no pattern VEP and no flash VEP, there is still a detectable response from the macula. P50 is smaller than its fellow eye, and there is marked N95 component loss, bilaterally in fact, but there's also a shortening of P50 peak time. And if you look at the shape of this response, that's exactly what happens when you, this is Laura Frischman's work, when you inject tetrodotoxin, which blocks all spiking cells into the vitreous of a macaque. There is almost complete loss of the N95 component. P50 becomes shorter and smaller, but it does not become extinguished. Just to summarize with the type of the abnormality we get in ERG, if we have dysfunction of the photoreceptors, that will affect the photoreceptor-derived A wave and give global ERG reduction. Whereas if we have primary disease, either at the bipolar cells themselves, the synapse, or in the inner nuclear layer, then we will preserve the photoreceptor-derived A wave, affect the positive going B wave, leaving a negative going wave, which is known as an electronegative ERG. Thank you for your attention.
Thank you very much, Graham. And we've now got some chance to discuss your presentation. And please post any questions you have in the Q&A box. But whilst we look at that, may I ask a question, Graham? May I ask, in your view, can we make these visual electrophysiological tests that are really quite complex, can we make them more accessible? How do you think we can best go about that?
Accessible to whom?
Yeah, more widely to different clinics, perhaps. They tend to be in tertiary referral centres, don't they, often?
Well, one of the challenges, of course, is that the technicians need to be adequately trained. The recordings are not that simple to do. It's not as simple as taking an ophthalmic technician, teaching them which buttons to press on an OCT machine, and you get half-decent responses. The technician has to understand what they're doing. They have to recognize the signals. They have to deal with artifact. And the role of the technician is absolutely fundamental, because if the data which come to me or to you or to whoever's going to interpret those data are not 100% at the level they should be, then the interpretation is meaningless.
No, it's very valuable, isn't it? It's important that we get training established, I think, internationally.
Yeah, and I think the same applies to the people who do the interpretation. It's best if people have a subspecialty fellowship rather than just look at an ERG and say it's there or it's not there, because you have to understand the origins of the signals before you can relate the origins of the signals to the signals that are recorded in the patient, and therefore relate those signals to the underlying pathophysiology of the disease.
Yes, I've got one other little question, which is, would you actually have one test that you would always use in every situation? Or
No.
would it always vary?
No, because it would depend on the clinical question.
So you would always select them. I wondered whether you had a particular penchant for the pattern ERG, as you were, quite instrumental in making that applicable widely.
It depends what the question is. I mean, if you're dealing with a 3-month-old child who's questionably blind, then a pattern ERG is not going to help you very much.
No, that's quite true. That's quite true. Okay, so I think now, thank you very much, Graham. There are no further questions at the moment. I'm sure there'll be more later. Thank you.
And thank you very much for your kind introduction, Dorothy. That was very kind. I'd now like to welcome our second speaker, Bart Leroy, who will discuss Dr. I Can't See to Read, Retinal Structure and Function. Bart is the chairman of the University Hospital in Ghent in Belgium. He's an outstanding electrophysiologist, geneticist, clinician, and human being. Bart.
Hi, everyone. My name is Bart Leroy. My brief is to talk to you about Dr. I Can't See to Read, and then talk about structure-function relationships in disease affecting the central part of the retina. So this is the overview of what we're going to do. Obviously, in the space of 13 minutes, not every condition can be addressed, and so these are the conditions that I'll be zooming into, giving you, I hope, a good view of what is structure-function relationship in the central retina. Before we jump into that, rods and cones are a topic that one might just do a quick refresher on. We have about 120 million rods per retina, and they give us navigational vision at night and do not function in daylight. The cones are about 6 million, so 20 times less than the rods per eye, and they give us sharp vision in daylight. They give us color vision, but they're also responsible for the color vision at night. So let's first look at the condition called Stargardt disease. Patients will generally present with early visual loss. Signs in the back of the eye will be the beaten metal type fovea. Some people will already have yellow-white deep intraretinal flecks in a fishtail-like manner. Chorioretinal atrophy is seen later on, but initially you can be fooled and the retina may look normal and people may think this is functional visual loss. So this is a genetic condition that is always due to mutations in both copies of the ABCA4 gene. It is an autosomal recessive condition, so finding just one mutation in one copy of ABCA4 is not good enough. What does the protein encoded for by the ABCA4 gene, which is also called ABCA4, do? Well, it moves, as you can see in this slide, the fuchsia rose or pink protein, ABCA4, moves used vitamin A in the outer segments called all transretinal out into the interdiscal intracytoplasmatic space for it to then get into the interphotoreceptor matrix and then into the RPE so that it can get recycled. If you don't do that, it accumulates in the outer segments. It'll degenerate into toxic products and therefore cause disease at the level of the outer retina. A classic phenotype of what is Stargardt disease is seen in this lady who presented the condition later on in life, but it still is very classic. You can see the flecks, you can see that they focus in the macula and around. But you can have other types of Stargardt disease. On the left, you see someone who is barely affected, but did complain of visual issues. In the center, you see the early stage of classic disease where the flecks are yet to come, and atrophy can be seen in the central macula. And on the right, you see a late stage severe disease where atrophy of the retina is much more extensive than just in the macula. So when we do electrophysiology, we will find in the majority of cases a normal full-field flash ERG testing the generalized retinal function. What we also will have is a pattern ERG that will always be abnormal. Now, let's illustrate this with a case. You have to, as a differential, think about other conditions, including Batten disease and Cone disease. We'll talk about those later on. So let's first look at this 10-year-old girl, unexplained loss of vision, referred by a fellow ophthalmologist who was querying whether this could be potentially a functional visual loss. And the father's jailed 6 months prior to the consultation. So there are all kinds of reasons why it could be stress-related or functional. So this is the fundus. You can see that both eyes in the central part of the macula have this greenish yellowish hue, which is very suggestive of early stage Stargardt disease. We do a full field flash ERG, normals at the bottom for you to compare. At the top, you can see that the traces are essentially normal. So the generalized retinal function is normal. But if you zoom in over time into the central macula, you can start to see the white flecks appear in the maculae around the center, where you can see that white flecks start to pop up on this blue light autofluorescence image. When you do a pattern ERG on the top right-hand side, initially 1 year after the first visit, actually, you can see that the P50 expressing input into the retinal ganglion cells, so photoreceptors basically, you can see that down from what is normal. And over time, at the bottom right-hand side of the slide, you can see that it's all flat. The N95 is specific for ganglion cells. They don't get much input if the fovea and perifoveal macula are not working properly. So this is very suggestive of Stargardt disease, and the clinical picture becomes more clearly in keeping with Stargardt disease. So this is Stargardt disease as diagnosis, not functional visual loss. So let's look at another condition. Let's look at something that primarily affects the retinal pigment epithelium. And we are now talking about best vitelliform macular dystrophy. It is a condition that is typified by the presence of an egg yolk-like lesion in the central part of the retina, and visual acuity declines but remains fair in at least one eye until later on in life, say 40, 45 years on, depending on the patient, but that was generally seen in systematic studies. But all people, in the old days, now we think the large majority of the people have an abnormality on the EOG electrooculogram. So there are people who classify best vitelliform macular dystrophy in stages. We're not going to do that in this talk, but here you go. You see on the left an early stage at age 7, photos taken in the old days by my predecessor, Professor Delay, shows you beautiful egg yolk-like lesion. And over time at age 50, that is 43 years later, you can see that it does change over time towards a vitellioptive phase, as you can see. What is BEST1? It encodes bestrophin, and there are 4 BEST genes. BEST1 encodes for a regulator of RPE calcium channels. Some people say these are chloride channels. Some people say they're calcium channels. We think that it is a calcium-activated chloride channel in the basolateral surface of what is the RPE. The best vitelliform macular dystrophy is just one of what we think are 3 different bestrophinopathies. We can't go into it in detail here. What you can see here is abnormalities in the central retina in a case. Typical egg yolk-like lesion, and EOG is flat. The light peak to dark trough ratio is abnormal. All the rest is normal. So this is best vitelliform macular dystrophy, and we've proven that through molecular screening. So let's look at the next condition affecting the central part of the retina. So what's X-linked RS? It's a condition that basically affects men due to a mutation on the X-linked gene RS1, and RS1 encodes retinoschisin, retinal glue that keeps together all the individual layers. They present with loss of central vision. All of them have some sort of central retinal abnormality. Some, 50%, have retinoschisis in the periphery, as you can see, and some are born with a retinal detachment. Here you see typical signs of both the central part affected by this cartwheel appearance of retinoschisis, and the periphery can be scytical as well, as you can see at the bottom side. Visual acuity can be normal, but most of them at school age will present with loss of vision. As I said, RS1 encodes retinoschisin, basically retinal glue. We're not going to go into the details here, but here you can see that the splitting of layers, which is schisis, is more prominent in the central part, but it actually goes way beyond it and is present at several levels when you look at the OCT. But let's look at a case, a 49-year-old gentleman who's never been perfect as far as vision is concerned, and he's complaining of loss of vision lately. He's worried about his son's future. In his pedigree, you can see that there's potentially X-linked disease. This is him, best corrected visual acuity 110 both eyes. You can see on the Goldman's that centrally there's a scotoma. And here you see small whitish flecks in the central macula. If you go beyond that, there's nothing to be had. If you look at the left eye, the same thing is there, little white dots in the center, and then nothing to be had in the retinal periphery. You can see that much better on near-infrared reflectance and blue light autofluorescence image, but they don't add anything to the case really. You can see on OCT, however, that the central part lacks the photoreceptors that you would expect still to be present, and there's surely not any scytical change at all anymore. What you can see, however, is this on a full field flash ERG. And this is an electronegative ERG. And an electronegative ERG is typical of X-linked RS. And so this is a late stage disease where you don't see the cystoid degeneration of the retina anymore. The splitting is not apparent, but you lose outer retinal cells, the photoreceptors, and vision goes down even more. X-linked disease, proven not to be a risk for kids. Let's look at cone dysfunction. Generally speaking, problems with cones. Here you see 9 genes, 15 genes, and 1 gene, depending on dominant, recessive, and X-linked. You can see that they're involved in phototransduction, they're involved in transporting the photoreceptors, in development of photoreceptors, in phototransduction again, in structure, and even in vitamin A recycling. All of these genes can be at the basis. Let's look at an example again. Goldman visual fields full, but they show an issue centrally. Color vision's really bad in this gentleman, and you see a central bullseye lesion. This is typified even more on blue light and near infrared reflectance or autofluorescence image and reflectance imaging. And if you look at the, ERG, you can see on the right top hand side of the traces that the cone specific responses, the single flash and the 30 Hertz flicker, are the most affected. This is a gentleman with a central lesion, central visual loss, but he has cone involvement throughout the retina. Here you can see the center, and you can see that it is devoid of many of the photoreceptors that you would normally like to see present. He's proven to be X-linked cone dystrophy, RPGR mutation, and proves the case, basically. The last thing that I want to just quickly dwell on is achromatopsia. No cones work genetically, and we can have that due to 2 mutations in any of those 6 genes on this slide. We can't go into them in detail, but suffice it to say that the majority of them is involved in the phototransduction at the level of the cones only. So the rods seem to work, but the cones don't work congenitally. They are still there, but they don't work. What you can see here is actually a fairly normal looking retina at all levels with all kinds of multimodal imaging. And in the ERG traces, you can see that the right-hand side is flat. There's no cone-specific responses, neither on single flash nor on 30 Hertz flicker stimulation, whereas the rods are normal. Here you can tell on OCT that some of the people, that the bottom example, for example, have issues with central photoreceptors. So those cones are not present anymore, whereas they are probably present beyond that central macular lesion. In conclusion, I hope to have shown you that we have progressive and stationary diseases. Achromatopsia doesn't really change much. Solitary, but we have to think about the fact that some of them can be syndromic too. And then photophobia, night blindness, these are all things you have to talk about to your patient. Classic Mendelian inheritance patterns are applicable, and so therefore do draw pedigree. It'll enlighten you as far as problems of the patients are concerned. And patient history taking, as I said, is crucial. Genotyping has to happen to confirm the clinical diagnosis. With that, I thank you for your attention and enjoy the rest of the course.
Thank you very much. The audience seemed to be rather reluctant to ask questions. So perhaps I could ask one. We're now using autofluorescence imaging, OCTs regularly. How often do you think we should be using wide field autofluorescence?
I think it is very helpful. So there's an additional value in the sense that I'm immediately thinking about autosomal recessive bestrophinopathy due to 2 mutations in BEST1. You can definitely see changes far out in the periphery that are not that you're not able to catch with 55-degree fields. However, I do not yet have it. I'm definitely going to invest in it. But I'm still very much able to do my clinics without. So I think the autofluorescence in the central part is much more important than it is in the periphery. For those acquiring instruments that allow you to do autofluorescence imaging, I would say have a look at the wide field immediately.
May I ask a question?
Of course.
Sure.
Thank you. I was just wondering, what guidance or what are your guide points for signposting electrophysiology? When you have a structural abnormality, do you ever think, oh, that's fine, I know what that is? Or would you normally go into electrophysiological testing?
I would say the evaluation that we do in our genetic ophthalmic clinic is one where imaging is virtually never on its own. So I think that I hope that during the talk I've shown that some things may pop up in the center, but actually when you then do generalized screening or screening of the generalized function, you are so much more easily guided towards the correct diagnosis that I cannot possibly see a role for just imaging in any of the really thorough clinics that we ought to be doing at academic centers and larger centers that are non-academic. So personally, I believe that functional testing should go hand in hand with evaluation with imaging. There's a question I see in the Q&A, which is Panagiotis Salvanos, who is asking which color vision test do you prefer clinically? So we in Ghent, Panos, what we use is basically a combination of the Ishihara. Obviously, that's only able to pick up red and green abnormalities. We do a Hardy-Rand Rittler and we do a panel D15. If you have one of them, I would say probably Hardy-Rand Rittler, because that is able to tell you something about red-green deficiencies and blue-yellow deficiencies, and is able to show you some level of degree of involvement of those color vision axes.
But would you use the desaturated or the saturated D15?
I think that in daily life, in the daily clinic, the desaturated one doesn't have much of an influence on clinical decision making. It is very subtle what it shows, and so I think I don't know whether you have tried it, Graham. I've tried to do the panel D15 desaturated. and I'm not certain that I'm always scoring perfectly well. So I think it is quite hard. There's another question. I don't know whether there's time. Once you diagnose an inherited retinal disorder, do you tend to follow up patients by electrophysiology? Yes, I do. Do I? So yes, I do, by all means. So I think that electrophysiology is one means together, hand in hand again with the imaging, to follow up how the phenotype in a patient evolves. And I'm not saying that at each visit I will do both. I will do as a minimum the imaging, but definitely, for example, an RP patient who comes in every year, I will probably do every 2 to 3 visits, I will do electrophysiology. Obviously, if the ERG is flat, it's not going to come back. But in people with remaining function, I certainly use electrophys as well.
Do you use it at all in a prognostic fashion in that degree, Bart? The rate of deterioration, possibly the extent of delay in a flicker ERG in an RP patient?
I would certainly, and I would certainly also do so in those cases of RP that are known to be very variable in expression. So some of the conditions are known to be very variable from one person to the other. PROM1, for example, is very classic. It's not that every person is as affected as the worst case. And sometimes you get people affected at 45. Some people have disease in the same family at age 5. So I certainly would do that. What machine do you prefer for autofluorescence? I'm not paid by any company. Personally, I think that the Heidelberg Engineering HRA is a very good one. I think that is the most dispersed throughout the world. And so for studies, for example, it's the one that people ask, whether you have that. But there are many others that are pretty good, actually.
Yeah, not all of them have the right paradigm in the sense that the optic disc, because there's no photoreceptors there, should be black. But in many of them, I mean, we have a variety of, in the different hospitals I work, a variety of different autofluorescents, and a number of them, the disc actually is white, or at least it looks as if it's reflected.
I fully agree, Graham. Yeah.
Whereas the spectralis is much better.
You can do a bad job with the spectralis as well by upping the sensitivity. So what Graham is saying is absolutely true. So a proper autofluorescence image using blue light, you can also do it with near infrared light, but with blue light, where you highlight lipofuscin content at the level of the RPE, you have to have a black optic disc, as Graham is saying. So I think probably that ends the Q&A session.
Thank you very much, Bart. Thank
you.
And so I would now like to welcome our next speaker, Isabel, who's going to discuss Dr. I Can't See in the Dark and retinal structure and function. And Isabel is a professor of ophthalmology in the Department of Genetics at the Vision Institute in Paris. And her exceptional clinical research has expanded our understanding of genetic mechanisms of inherited retinal diseases, coupled with electrophysiology, and is paving the way for new treatments. So thank you, Isabel.
Hello, my name is Isabelle Odo. I come from Paris, Hôpital 1520 and Institut de la Vision. I want to thank Graham Holder and the SOE for inviting me to this interesting seminar. And I'm going to talk about Dr. I Can't See in the Dark. So here are my disclosure. None of them are relevant for this presentation. Night blindness is sometimes a symptom that is overlooked, especially in our modern cities. There are various causes, very few being treatable, but they need to be recognized to appropriately be managed. One needs to distinguish between common symptoms that are not degenerative, especially night adaptation disturbances, in case of moderate to high myopia, especially if it's poorly refracted, or difficulty to dark adaptation linked to aging. Regarding causes of dark adaptation abnormalities, there's usually a genetic disorder, which is much more common, but also acquired disorder, which we'll review in this presentation. When managing a patient with dark adaptation, the first step is to take medical and personal and familial history, looking for causes of malabsorption, restricted diet, GI surgery, chronic diarrhea, chronic cholestasis or cirrhosis, history of cancer or inflammatory condition or medication, associated symptoms including light sensitivity, photopsias, decreased visual acuity, or abnormalities of the visual field, especially the side vision. And of course, asking for a family history and other cases in the family with a pedigree that should be drawn. Then follow an ophthalmic examination with a careful refraction, especially for myopia, but also a careful look at the presence or not of a nystagmus or fundus alteration. Kinetic visual field test and dark adaptometry might be helpful, but however, the key examination when dark adaptation is the chief symptom is full-field ERG. And this full-field ERG recording should be performed at least with the minimal ISF standard recordings, especially with this period of dark adaptation of 20 minutes at least. Then this full-field ERG will be followed by retinal imaging, and the two key multimodal imaging that are very important are fundus autofluorescence and SD-OCT. We will now review the different causes of night blindness or dark adaptation alteration. Far more are the most common are genetic condition, and the first one that to fear are degenerative. The most common cause of dark adaptation with retinal degeneration are rod cone dystrophies, also known as retinitis pigmentosa, where the fundus can be typical with pale optic beads, narrow blood vessels, and pigmentary changes. However, these pigmentary changes can be missing, especially in early stage of the disease or in case of high myopia. There's associated disorders that are affiliated to retinitis pigmentosa, such as those three disorders associated with chorioretinal atrophy, choroideremia, with this lack of pale disc, vessels become narrow with advanced stages, but also this large chorioretinal atrophy. GT crystalline dystrophy is another cause of chorioretinal atrophy or gyrate atrophy, a very rare disorder with this patchy scalloped atrophy from the periphery, usually associated with high myopia and early onset cataract. Another key feature of rod cone dystrophy and affiliated disorders is on the full-field ERG, the primary photoreceptor involvement with a severely reduced A wave under dark adaptation condition, which predominate compared to the photopeak responses, which are usually a bit more preserved, at least when the full-field ERG is still detectable. There's another very specific disorder, which is called Enhancescon Syndrome, which is usually mixed with retinitis pigmentosa, but should probably be distinguished first because the visual prognosis is a bit different than retinitis pigmentosa, and second because there's some very specific ERG features. The fundus can be variable with little dots that are hyper-autofluorescence, or when there's pigment migration, it's usually nummular around the vascular arcades. And one distinguished feature, which is very common, is also the presence of cystoid maculopathy, which actually is important for the visual prognosis. The full-field ERG reveals very distinguished feature. First, there's no rod function under a dim light stimulation, no B wave are detectable. Then, if you look at the response to a bright flash under dark or light adaptation, the waveform is quite similar. And actually what is happening is that the scotopic responses are dominated by cone responses, but these cone responses are abnormal. You can see with this very deep A wave and slow B wave compared to the normal response to a single flash under photopic condition, but also the flicker response has an amplitude that is below the amplitude of the A wave to a single flash, which usually actually the amplitude of the flicker should be between the A wave and the B wave of the single flash. This is very characteristic, but if you are lucky to have the possibility to do short wavelength stimulation, you can see that unlike a normal subject, the response to short wavelength stimulation would be very, very large. And this showed you that there's an enhanced response to or at least to short wavelength stimulation. So Enhancescon syndrome is a recessive disorder linked to mutation in this transcription factor called NR2E3, which is really critical for rod differentiation. When NR2E3 is mutated, there's no rod differentiation, and by default, all the retinoblasts that were supposed to give rods are actually differentiation in S cones, so there's an excess of S cones. Other genetic condition will be more stationary and also with normal fundus, except some affiliated disorder. So congenital stationary night blindness can be distinguished into two subtypes, the Rix types and the Schubert-Bonstein types. The Schubert-Bonstein is by far the most common. That's why I'm starting by that. What happened in the Schubert-Bonstein types is that there's a transmission defect from the photoreceptor to the bipolar cells. Therefore, on the ERG, the A wave under dark adaptation is normal, originating from hyperpolarizing bipolar cells, photoreceptor cells, upon light stimulation. But the B wave is severely reduced, giving an electronegative shape to the response, and really showing that there's a signal transmission defect from the photoreceptor to bipolar cells. Miyake in 1986 further distinguished Schubert-Bonstein type of CSNB into two subtypes, the complete and incomplete, based on the response to a dim flash under dark adapted condition. The complete form doesn't have any B wave, where the incomplete has this reduced and delayed B wave, but still present. The response to a bright flash under dark adaptation is similar, with the normal A wave, severely decreased B wave characterizing the electronegative ERG with the B2A amplitude ratio inferior to 1. Complete and incomplete can be further distinguished based on their photopic responses, showing this for the complete, this relatively preserved amplitude delayed response, but this characteristic square shaped A wave with sharply rising B wave. And when possible, long duration stimulation in the complete form will show selective on defect. So the complete form has no on response under dark adaptation condition and no on response to light adapted condition, which mean this is really an on bipolar defect. The incomplete form, however, has more severely affected photopic responses. And when performing long duration stimulation, both the on and off pathway are severely abnormal. Interestingly, the phenotype is slightly different. The complete form is more typical, with possibility of transmission as an X-linked or recessive trait, night blindness, nystagmus, strabismus, high myopia, and normal fundus, except for myopic changes, whereas the incomplete form is a bit more variable, mostly X-linked. Actually, night blindness can be overlooked, and the patient may complain more about light sensitivity. Nystagmus and strabismus are usually present. The refraction is a bit more variable. Myopia can be present, but maybe less commonly than for the complete form. Fundus abnormalities include, of course, myopic changes, but there's some cases of macular abnormalities that have been reported. Interestingly, all the proteins that are involved in incomplete CSNB usually localized at the photoreceptor synapse, therefore impacting both on the on and off pathway, whereas the complete form of CSNB is associated with mutation in proteins that localize the dendritic tips of on bipolar cells, both rod and cone on bipolar cells. Beside this Schubert-Bonshine type of CSNB, there's another type. It's the Riggs type, which is by far the least common and least characterized. In these cases, the primary defect is on rod photoreceptor. So there will be on the full field ERG under DAC adaptation condition, both a decrease in A and B wave amplitude, and most of the protein that are involved in this Riggs type of CSNB are actually implicated in the phototransduction cascade of rod photoreceptors. This is an example of the ERG that you can get. No B wave under to a dim flash under DAC adaptation. The A wave is severely reduced, but also the B wave, and we will come to that. In fact, cone photoreceptor function is preserved. And in these cases, DAC adapted responses are actually dominated by cone responses. And we may see this pseudo-electronegative ERG because under DAC adaptation, when this is a cone-dominated response, you can reveal what is called the photopeak hill phenomenon, which is a balance between the depolarization of the on-bipolar cells and hyperpolarization of the off-bipolar cells, with this push-pull phenomenon and this tension, this different tension that really characterize the cone system, giving this pseudo-electronegative ERG. Aside from this CSNB with normal fundus, there's other type of CSNB with abnormal fundus, such as fundus albipunctatus, characterized by these little white dots. This is a recessive disorder linked to RDH5 mutation involved in the retinoid cycle. In these cases, similarly, cone response are preserved, whereas rod response are altered. But if you do a longer DAC adaptation, then you may recover normal rod function. The other very rare disease is Oguchi, with this very typical goldish fundus, which disappear upon longer DAC adaptation. Aside from this genetic disorder, there's also acquired disorder, and probably the most common is vitamin A deficiency, which may be associated with a poor diet, liver condition, chronic diarrhea, and so on. In the fundus, the alteration may just be a subtle white, yellowish brisinoid lesion. And regarding the functional alteration, vitamin A deficiency is characterized by preserved cone function, but isolated rod dysfunction. Another frequent cause of acquired night blindness are inflammatory disorders, such as this posterior uveitis called Burchard chorioretinopathy. And actually, the group of Moorfield with Professor Holder really nicely demonstrated that when at the acute phase, Burchard chorioretinopathy is associated with inner retinal dysfunction that will resolve upon a treatment, and the ERG may be quite instrumental to follow and manage this patient to document a generalized retinal dysfunction at the level of the inner retina to monitor this patient. And I want to finish with very rare conditions such as paraneoplastic syndrome, carcinoma-associated retinopathy, which is a primary photoreceptor defect, or MAR, or melanoma-associated retinopathy, which really resemble the complete CSNB with both rod and cone on bipolar defect in the context of a melanoma. So the take-home message, as you see, there's a lot of causes of night blindness, and they are not all synonymous as retinitis pigmentosa. Full field ERG is very instrumental. It will document the dysfunction and also precise the diagnosis. Acquired disease may be recognized as well, and they can also be monitored by performing repeated full-field ERG, especially in the management of birdshot chorioretinopathy. And I want to thank you for your attention.
Thank you very much, Isabel. That was a lovely, comprehensive view of the rod retina. We've got some speaker here, so a rather question. So to all the speakers, do you ever perform any examinations out of the ICIP protocols? Why and when? So Isabel, do you?
Yes, I do. Actually, it's not very easy when you have a busy electrophysiology clinic, but I do think to get more deeper in the phenotyping of some of the disorder, especially I demonstrated for Enhancescon Syndrome or for congenital stationary night blindness. If you want to definitely document complete and incomplete, you may do additional testing. But I must say, already in the ICEF standard, you have some hint of this disorder.
Okay, thank you. And now we have another one from Anthony Calcadney. Considering vitamin A deficiency in the early and intermediate stages gives a cone-isolated retina, why do you think it sometimes comes with visual field defects?
This is interesting, and actually, it's to me, it's a recent questioning because I just recently saw a patient with vitamin A deficiency. I do think that, you know, when you perform full field ERG, you mostly test peripheral cones, and maybe Graham can also comment on that. And maybe there's some subtle cone dysfunction that you're not capturing with the full field ERG that you may see with static perimetry, for example. But I do think this is something that occurs not in the early stages, but probably in the intermediate stage when the vitamin E reserve for cones are also starting to wane, I would say. Mm.
Can I come in there?
Yes, yes.
No, I think that's correct. It doesn't occur in early vitamin A deficiency, but if you take somebody who's been chronically vitamin A deficient before they get beta spots and not that severe, that you will find when you actually treat the patient, there will be a slight improvement in cone ERGs. So even though the ERGs were cone isolated when first tested, and those cone ERGs can fall within the normal range, they still will probably show some improvement. So there is some loss of cone sensitivity. The cones, of course, have access to the fast recycling through the Muller cells that the rods don't have.
Thank you. So, gosh, lots of questions now.
Yeah.
So this is good. In the complete form of CSMB, why don't we see an A wave in the dark adapted dim flash?
Well, actually, I don't think we are supposed to see an A wave in the GA 0.01 ERG because you're so dim that obviously you have stimulated some of the rods, but your technique is not sensitive enough to detect the A wave. So even in a normal patient, so I'm not expecting to have in a normal patient an A wave, but just the B wave because they're amplification of the signal at the level of the unbipolar cells. But so therefore I don't expect even in complete CSNB. Mm.
Okay, so it's just below any threshold.
Exactly.
Okay, and then we have another. Is dark adaptation curve mandatory in any of these conditions? So
mandatory is a strong word. I think, to be honest, in a busy electrophysiology clinic, I don't do dark adaptation curve. But I do think when you're looking for a precise rod sensitivity, it would be really, really interesting. I don't know if you and Graham have some feedback for that. You may want to comment.
Graham, would you like to join in?
It's a difficult question for me to answer because I currently don't have access to it in Singapore. But while I was at Moorfields, what we found particularly useful was not just having straightforward dark adaptometry, but also dark adaptometry which tested dark adapting cones as well as dark adapting rods, which was a system which was developed by Chris Hogg and Jeff Arden. And that enables the detection of a disorder known as the when you lose the inhibition, usually what you've got is as the rods start to dark adapt, they suppress the function of the cones, and then the cone thresholds increase. And you can get a phenomenon called enhanced rod-cone interaction, where the patients actually usually present with glare, with driving, etc., but they have completely normal electrophysiology, completely normal anatomy, usually, but you can pick it up using dark adaptometry, providing you look at cone thresholds as well as rod thresholds.
That's very interesting. So that the trigger would be that you get that interaction. If
the interaction between the rods and cone system is great, hence the enhanced rod cone interaction, the elevation of cone thresholds, which usually would be a log unit plus, goes up to 3 log units, sometimes higher.
Gosh, that's very interesting. Thank you.
Described by Jeff Arden.
Excellent. Okay, so these are moving fast. There is one here which is about anybody having experience of using Retinal, portable ERG devices, and what we think about it. Have you used it, Isabel? Do you have a?
I've never used it. I'm very happy with my standard ERG, my full field and so on. So I wouldn't like to use it. I don't feel the need.
I think this is very true, actually. We do get very used to our own equipment and know its foibles and how well it works, don't we?
Yeah.
I think maybe this is something we might answer, or we could express answers offline for this, because I think we're getting close to the end of questions, I think. So thank you very much, Isabel.
Thank you.
Lovely talk. Thank you.
It's now my pleasure to introduce Dorothy, who is our next speaker. She has one of the most challenging roles in electrophysiology in running a purely pediatric practice. And she and her team are absolutely amazing. The skill with which they can get the most extraordinary, successful recordings in the most difficult children. Dorothy is the head of the Tony Chris Visual Electrophysiology Unit at Great Ormond Street Children's Hospital, probably one of the most respected and eminent in the world, and she has the same degree of eminence in pediatric electrophysiology. Dorothy.
So my name is Dorothy Thompson, and I'm going to be talking about structure and function in pediatric practice, based upon my experiences at Great Ormond Street Hospital for Children, and with a focus particularly on neuro-ophthalmology. So in pediatric practice, we really need objective tests of visual function. But we need it not only for children, but for others who may not want to, or perhaps are unable to communicate what they can see. And visual electrophysiology offers us an objective test of function, because the eyes, particularly in infancy, the fundus may look okay, but not work. The MRI brain may look okay, but not work. But in contrast, we may have a retina that looks damaged, as in this case, yet works perfectly fine, or an MRI brain may look damaged, but in this case, in holoprosencephaly, this girl had a visual area and could use it well. Now in ICEV, we know that there are 5 clinical test protocols that are described by standards. The middle 3 here that are bracketed are probably suitable for children of 5 years or more who are able to steadily fixate and comply with instructions. So that leaves us with a flash electroretinogram, or ERG, and a visual evoked potential, or VEP. And at Great Ormond Street, or GOSH, we've got an infant protocol so that in 30 minutes, we can acquire information about pattern flash VEPs with a modified skin flash ERG protocol. And these children are alert at the time of testing. We can do that by using handheld flash stimulation and, importantly, biasing the contribution of cones using red light and rods using blue light. And that's instead of having a lengthy dark adaptation period. Last year, we thought that we'd formally look at the diagnostic accuracy of our technique. And I'll just show you here in normal data across the top, plotted for the GOSH protocol in red and the ICEV ERGs in black. Using the dim blue flash, we are able here to show that we've got profound rod system dysfunction in CSMB and in the rod cone dysfunction. Or we've got cone dysfunction correctly identified. But importantly, we also look at the shape of the ERG, and we can correctly identify negative ERG waveforms, and the shape matters. And we found overall that there was very high diagnostic accuracy and excellent overall sensitivity. So let's put that to the test. Here we have a 2-year-old girl who was referred to us for regression of developmental skills from 18 months of age, and her attention visually was very variable. She had dribbling and an unstable gait. Now, compared to normal ERG waveforms on the bottom, these are her waveforms, and we can see that she lacks a rod-driven B wave, and also that she has an electronegative ERG here, lacking a B wave. Now, an electronegative ERG in this context of progression signposts CLN1, early infantile MCL, or Batten's disease. There are two, the infantile and the juvenile forms, that are associated with electronegative ERGs. CLN3, the juvenile type, will often present first to an eye clinic with visual loss due to maculopathy. Now, the retina in these neurological diseases is the progression is unrelenting, and it leads to blindness. But in addition, those patients with Batten disease have very severe cognitive and motor decline and seizures and premature death. Now, whilst these are rare, the NCLs are the most common of the childhood neurodegenerative disorders. So it all looks pretty bleak, but there is some encouraging report of treatments working in slowing decline, particularly in CLN2, late infantile disease, by directly introducing a human recombinant enzyme into the ventricular system. But this is not changing the progressive retinal degeneration, most probably because of the spectrum of the eye's immune privilege. But there have been some reports recently of some slowed retinal degeneration in the canine model of CLN2. But as yet, we don't know enough about the human disease. There have been attempts across the world to look at the natural history and pool resources. And so there is a disease clinical rating scale that has two domains of motor and language skills. And this has proven to be very successful and have concordance across different centres and different raters. More recently, an ophthalmic severity score, which was based on the appearance of the macula, has been published. And here I've shown some images taken from our cohort of 20 patients with late infantile CLN2. And it shows the grading in this column going from fairly normal to profound atrophic changes at the macula. In doing this work, we also came across patients such as this, where there appears a foveal deposit, which is going to alter the foveal thickness measure when perhaps there's more degeneration than you might think. And then of interest, we also noticed this foveal hyperfundus autofluorescence, which has been reported, of course, in association with achromatopsia. So of these 20 patients, we went on to look a little bit more in detail at the ERG and highlighted the profound cone loss of ERG, which was a lot greater than rod. And this is illustrated in this patient who we saw in 10-month interval. And at this point, we can see that there's a diminution of the rod B wave, but a much greater loss of the cone flicker ERG. So we can conclude that the CLN2 retinopathy functionally is a symmetric cone rod dystrophy. The symmetric aspect is important if we're going to use a fellow eye in treatment as a control. And it has early structural signs of maculopathy. We went on a wee bit further to look at the trajectory of the visual decline. And here we have used individuals linked by lines to see the loss of their ERG, which you can see is precipitous. And we did that by dividing the amplitude of their responses by their lower reference range to give us this index. This allowed us also to combine data from other centres. And overall, classical CLN2 disease shows a rapid visual loss between the ages of 3 and 7 years. We also went on to use the work of Kovacs, who had done a prediction interval for the decline of the center subfoveal thickness. And we've plotted our data here as these black spots, and they fit it quite well. But of note, it's slightly later before these thicknesses fall below the reference limit published by Lee for central thickness in pediatric patients. We looked also at combining the ERG with the CST, the OCT subfoveal foveal thickness measure directly, and we got good concordance when it was the average DRG. But we show some separation again when we get a bit more specific and look at the cone function, seeing that there's functional loss before thinning. So we have a slight disparity again, where function is preceding structural change. Now, so far, we've looked at the flash ERG, which is summated across the whole retina, but the macular contribution is negligible. But we can, in kids, use the pattern VP as an indirect index of how well the macula in the retina is working. So pattern VP is an index of macular pathway all the way from ganglion cell to the striate cortex. But it gives us this opportunity in certain retinal diseases, such as Usher syndrome ciliopathy seen here, where we have an absent full field ERG, but the OCT is showing this preservation of macular structure, which is sufficient to give us a pattern VP. And this could be a surrogate marker in some retinal diseases of progression, or potentially of treatment efficacy. But there is a note here, particularly for neurodegenerative diseases, that the VP is part of the EEG. And if we have a non-seeing child who has no nystagmus with background EEG and seizures, is something that we must consider. So if we have a flash stimulus here, we take in a certain amount of time of EEG afterwards, but it looks very random. We repeat and repeat and repeat until all the random activity cancels out and that time lock to the stimulus appears. And this is the pattern reversal VP, for example. So as an analogy, these paddle borders are the VP or visual signal, and we can detect them, and the child can detect them if the background wave, EEG, is low. If, however, we have a large background activity or seizure activity, the child will be behaviorally blind because they will not be able to use the signal, nor may we get a pattern VP. The second feature of the pattern VP is its timing, and that develops rapidly in the first 7 months of life, down across this trajectory to 100 milliseconds. These elegant data plotted by Esther Mikobarata, a colleague from Hungary, have also plotted premature time to peak of the P100. It looks as though the premature babies are delayed, but if there's a correction for gestational age, counting from 40 weeks, they follow the same trajectory. And so the important thing is here is that in uncomplicated delayed visual maturation, the peak time is normal for age, and also for premature, we count from 40 weeks. So let's put this into practice. We monitor optic pathway gliomas in the ophthalmology clinic using pattern VPs. Pathway gliomas account for 5% of intracranial tumors in children. And the patient I want to talk about, we saw when she was 5 years of age. But she was diagnosed at 1 because of cafe au lait spots with neurofibromatosis type 1, and her father and brother were similarly affected. Because of visual deterioration, she had an MRI that unfortunately showed a massive chiasmal glioma, and it extended anteriorly and posteriorly, and the neuroradiologist has kindly labeled where the chiasmal extent is here. But there were enhancing components superiorly in the hypothalamus and subthalamic regions. The issue arose because 5 months follow-up with an MRI showed an increased volume of the tumor on one side on the right, but a reduction on the left. And we were asked about the functional consequence of this. Now, generally, if vision deteriorates, it's a trigger for treatment. We look for a 2-line difference in visual acuity, but you can see here her follow-up is very similar to her preceding visual acuity. But the pattern VPs showed a marked prolongation of time to peak. The follow-up is in magenta, the baseline is black, and I've arrowed the increase in time to peak or latency of over 20 milliseconds, very significant. If we look at the structural effect, we can see that there are two segments that have just thinned slightly to move into amber by about 5 microns. So we have functional and subtle structural evidence that this tumor is impacting visual pathway function. Now, another thing we look for with pattern VEPs is to detect signs of chronically raised ICP. Now, the gold standard clearly for detecting this is a direct intracranial pressure measurement, ideally overnight with a sleep study. But otherwise, we may look for copper beating of the skull, or we may look for swollen discs. But we know that fundoscopy overall has got low sensitivity. But once we stitch it, it's very specific. Recently, we've got some helpful information from Swanson et al. Because they have looked at OCTs in children who have directly measured ICP. And they've come up with two values. They have a maximum central anterior projection, seen here in turquoise, and a maximum thickness of the central retinal disc. And these two values have a high sensitivity at detecting intracranial hypertension in children, which is wonderful that we sometimes do now have an actual measure, but very hard to achieve OCTs in some of those kids. So for a long time, we have looked for a reducing VEP amplitude over time to forewarn us of a reversible visual pathway compromise with raised ICP. And this can happen before changes in the optic disc or visual acuity. So we know this, but we were very curious to use this opportunity of studying 30 children who had had 48-hour ICP monitoring. And 22 of them had at least 3 serial VEP recordings. And we found that the sensitivity for detecting intracranial hypertension was 70%, whereas the specificity for an isolated VEP was 83%. And the 70% compares it's very, very similar to some colleagues in America who had published some data in a smaller group. So we know that the VEP is a very important adjunct in looking at raised ICP. But I wanted to include this because this was unexpected. These are giant VEP amplitudes. I've plotted amplitude here, and this 76 microvolts, that's the upper limit of the small check ISEV response. And these are data from a 4-year-old girl who had sleep apnea. She was confirmed as having Crouzon's disease, and I've plotted her VEP amplitudes being giant, recovering a little bit, and being giant again. And her ICP measures were high. My reason for including it is to show how when we get giant VEP, is the lag of 3 to 6 months before we get a papillodematous appearance and a change. You see as the hotspot here. So function is preceding structure. And a final case here with pattern VEPs applied in a case of macular schisis in a 4-year-old boy with very poor vision, 0.7 and 0.6. And at time of referral, he had normal looking discs and no pallor. So we were looking for widespread schisis, but the flash ERGs showed a normal B to A wave ratio. Unexpectedly, the flash VEP was really abnormal. So too was the pattern reversal VEP. It should look like magenta control. And so these macular pathway changes were disproportionate to the schitic changes. Went in for an MRI, which showed symmetrical atrophy of the optic nerve, chiasm tracts, but no significant intracranial pathology. But the genetics showed missense mutation in OPA1 and dominant optic atrophy was the diagnosis, with a hearing problem subsequently under investigation. And these schitic changes were actually the microcystic changes that have been associated with optic atrophy. But it was the disconnect between structure and function that helped us distinguish this case. So in conclusion, visual electrophysiology is a powerful and objective functional complement to structural measures, and it can detect dysfunction before structural changes. But we have a lot more work to do to understand the relationship of structure and function in the natural history of some of these rare retinal diseases that are associated with systemic disease. And so finally, just with my thanks to the awesome visual electrophysiology and imaging team at GOSH. Thank you.
Dorothy, thank you very much indeed. Again, the audience seemed to be rather reluctant. I wonder if I could ask a question about electrodes. With young babies particularly, and somewhat awkward young children, the choice of an electrode can be slightly awkward. We can try sometimes get DTLs in because they're reasonably well tolerated. Gold foils you don't have a chance with. Sometimes we use surface electrodes on the lids. Of various different types have been tried. I wonder if you'd like to describe your experience of which types of electrode you find most successful.
I think for the infants, the very young children, and particularly when they're mobile, it's very nice to have surface electrodes, gel surface electrodes, so self-adhesive ones, and they simply can sit under the eyelid and won't come off that easily unless you've got quite a determined sort of rub. And then for ICVRGs, as in talking about putting yourself in a Ganzfeld and wanting a corneal electrode, we all use a DTL. Similarly, because it doesn't fall out as easily as much, and it can go down to the lower fornix, but there it will sit happily and securely, and we'll get a complete recording, a complete dark adaptation without having to redress or tweak it or alter it in any way. And otherwise, for recordings and electrodes over the scalp, we use standard EEG silver chloride electrodes with a cushion of the salty cream and then a Coban, as in vet wrap, as you might have on horses' fetlocks. It's a stretchy bandage, like a physiotherapy bandage, and that will actually just attach to itself, keep things in place. And so whilst a child is sitting on mum's lap, you know, these have to be reapplied occasionally, but for the most part, we manage to keep everything there and intact. But the key thing about using a surface electrode is actually technically to try and get the cornea down over the electrode, so that we know that the cornea apex gives us the biggest signal. And so if we have a surface electrode on the lower lid, if you like, or the lower cheek, then looking down over it will optimize your response. Because if a child is gazing up or has a strabismus, then we have to account for that direction and also where your reference site is. So technically there are a lot of dynamic changes that you can make to make a successful recording in kids.
Yeah, very important points. Given the DTL changes in amplitude, probably about 25% between the lower limbus of the cornea and the lower conjunctival sac, would you therefore counsel that in children routinely, you should put the electrode in the sac to guarantee stability of position and trial-to-trial variability reduction, rather than go for the maximum amplitude that you would in an adult by putting it at the lower limbus of the cornea?
You know, that's a really good question. And we do let it go a little lower than actually quite a firm adult, you might say. So we will accept the lower amplitude for the stability. And I think as a sort of technical note, it's easier that way to do and to do that as a first.
I know once when we were doing a multi-center trial using lots of different labs all over the place, this was in adults, not children, but we asked for the electrodes to be placed in the lower conjunctival sac to guarantee that there was going to be less retest variability when the patients came back over the years.
Yes, absolutely.
But sacrificing amplitude for reproducibility.
Yes, I think that's very important. I mean, it's rather like having a surface electrode.
Now, there's a question in chat. Do you ever use chloral hydrate or any other anesthesia in children who are not so cooperative?
No, it would be, sometimes we wish that we could. So, but we actually work in pairs, and that's the way in which we deal with alert children. So we don't routinely, the reason for it perhaps is that we don't have the resources, because you need this full crash team resources, even if you're going to be using sedation. We also know that chloral hydrate, sometimes they can go hyper with it. It may not have the effect that you like. So you might have more time spent with them running up and down the waiting room before they sort of conk out as such. Now that said, so we work in pairs, we distract and we record, and we work very closely as a team. That said, there are occasions when we can't get close to a patient, and particularly if it becomes a danger to us, if somebody is quite large or they're quite, I suppose, quite able to whack us one or something and nobody can get to see them. If they're going to have an EUA for their fundus examination, we will go to theatre and we will do the whole 9 yards. So we will, with the anesthesiologist's assistance, we will go for the full dark adaptation. The problem there lies with using the inhalation anesthetics. So like propofol, for example, that's been shown by Welleber's group that it can reduce the B wave by about 50%. And whilst they compare their data to data acquired under anesthesia, so reference data, we don't have that reference data. So if we have a reduced B wave, we think, okay, but we really go to theatre to look for the A wave and photoreceptor function. So that would be our reasoning.
Yeah, my thinking is pretty much the same. And I think the difficulty with anesthetics is that a lot of it, you're working on the assumption that the retina has reasonably normal function to determine what the effect of the anesthesia is. But if you've got a degenerate retina or you've got conduction problems at a synaptic level, who knows what the anesthetic is going to do there?
Yes, very true. Very true. No, we so rarely, but we rely on this awesome team, as I say, working in pairs. Okay.
I think we've come to the end of the Q&A.
So I think it's now my turn, Graham, to ask you to come up and introduce you for your final speaker of this evening's presentations, and you're, I think, going to discuss how specific are structure-function relationships in retina and optic nerve disease.
We now look at structure-function relationships. We'll start with the patient who was referred by an ophthalmologist to establish normal optic nerve function. The patient was mildly myopic, variable fields, touch of colour vision disturbance, but it was really to reassure. And yet when we performed the electrophysiology, the VEP is delayed. The VEP, as we know, is a non-specific response, so we have to do a PATNI-RG to localise the dysfunction. And the PATNI-RG is markedly subnormal bilaterally, so the patient has bilateral macular dysfunction. That then needs a full-field ERG. The rod-specific and bright flash dark adapted ERGs indicate normal rod system function. And then if we look at the cone system, there is marked delay indicative of generalized cone system dysfunction. So the patient has a cone dystrophy phenotype and the imaging is normal. Fundi are normal, autofluorescence imaging is normal, macular OCTs are normal. Now this is a patient who's got bilateral disc pallor, bilateral acuity reduction, diagnosis of heredofamilial optic atrophy, which was questioned because there's no marked ganglion cell loss on the OCT. And then when we look at the electrophysiology, the rod-specific ERG is normal. The red flash under dark adaptation, which should have an early cone component and then a rod component, has no cone component whatsoever, at least markedly reduced. The flicker ERG is generally delayed and subnormal, and the PATNI-RG is undetectable. So this patient indeed has a cone dystrophy with disc pallor. And this is a patient who's got pale discs, another patient with pale discs. And here we see central scotoma. And in this patient, the pattern VEPs are undetectable, the flash VEPs are very abnormal. But the PATNI-RG now shows a normal P50 component, slightly smaller from the left eye, with reduction in the N95 component, indicative of ganglion cell dysfunction. So this is optic nerve and retinal ganglion cell dysfunction. ERGs are normal, and the patient had a variant in OPA1 and has dominantly inherited optic atrophy. So the learning points from these cases are that normal structure does not mean normal function. A VEP delay does not mean optic nerve disease, and disc pallor does not mean optic nerve disease. So what about specificity of imaging? You can have the same disorder with different appearances. All of these patients have variants in the same gene. Some have normal fundi, some have a bullseye type lesion. When we look at the autofluorescence, mostly foveal abnormalities, some with frank hypoautofluorescence, some with a ring of hyperautofluorescence surrounding the fovea, some with speckled hyper and hypoautofluorescence of the fovea, and they're all different, and they all have the same disease. They all have cone dystrophy with supernormal rod ERG and variants in KCNV2. These patients, again, all have variants in the same gene. This patient has normal fundi. This patient is one of Isabel Aldo's, has white dots which hyperautofluoresce on autofluorescence imaging. This patient has hyperpigmented areas which hyperautofluoresce on autofluorescence. Here, there's nummular lesions around the arcades. The only preservation of the autofluorescence is centrally. This patient with a banana type lesion with hypo and hyperautofluorescence. Central schisis, and the classical nummular lesions here are those of Enhancescon Syndrome, related to mutation in NR2E3. Now, those two disorders were chosen because they are two of the three disorders in which the ERGs are pathognomonic or diagnostic. You need no information other than the ERG. That's rare, and these are the only three disorders in which I'm aware. But you can also get similar appearance from different disorders. So all of these patients have been selected on their central foveal hypoautofluorescence, some large, some small, some with a bullseye type appearance, some with a ring of hyperautofluorescence, some with a ring surrounding, and they all have different disorders. There are some duplications with PRPH2, KCNV2, etc. AIR is autoimmune retinopathy. And these all have similar appearances and yet quite different disorders. What's important also is that most of these disorders are associated with generalized ERG abnormalities and generalized retinal dysfunction, and yet their autofluorescence abnormalities are localized at central retina. Further, you can have the same genetic variant with a different appearance and a different functional phenotype. This was first described by Dick Welleber's group back in 1993, who showed a single family where you could get retinitis pigmentosa, pattern dystrophy, and fundus flavi maculatus in relation to a similar deletion. These four patients all have the most common PRPH2 abnormality, the 172 mutation. In this patient, it's a macular dystrophy. In this patient, the phenotype is that of a cone dystrophy, normal rod function. In this patient, it's a macular dystrophy. And in this patient with disease apparently confined to the macula, has very severe generalized cone rod dystrophy. This patient has parafoveal white dots and presents with visual acuity. There's some hyperautofluorescence on autofluorescence imaging, but no old-fashioned OCT abnormality. When we look at the electrophysiology, although one suspected a macular dystrophy, the presence of an abnormal rod-specific ARG confirms that this is not a macular dystrophy. There is generalized rod involvement. The bright flash ERG is slightly electronegative with the B wave smaller than the A wave, so this is generalized inner retinal dysfunction. The flicker ERG is delayed. The single flash cone ERG shows reduction in the B to A ratio, but with overall waveform preservation, unlike the changes in CSMB, where the waveform is dramatically changed. This is simply a B to A ratio reduction. So this is generalized inner retinal dysfunction with macular involvement, and screening showed involvement of RS1. So this patient has X-linked retinoschisis without the classical features. And when Steve Sang was doing a fellowship with Alan Bird and myself back in the late 2000s, we published a series of, I think it was 6 or 7 patients with X-linked schisis, typical ERGs who presented with parafoveal white dots. Typically, of course, patients with schisis have the spoke wheel lesion visible at the fovea, best seen on autofluorescence imaging, and profound scosis on OCT. 50%, of course, will never show peripheral schisis, and the classic spoke wheel lesion will often disappear and be replaced by non-specific macular atrophy as the patient ages. These 3 patients all have molecular confirmed schisis, typical ERGs, and totally atypical imaging, both the autofluorescence and the OCTs. So identification of the functional phenotype or the genotype by structural features alone may be impossible. Now, this is a patient who has a bifid subfoveal cavitation, long-standing visual acuity loss since childhood, and has, I won't go into these in great detail, typical ERGs for KCNV2 or cone-distributed supernormal rod ERG. No rod-specific ERG, very high amplitude bright flash dark adductors, and generalized cone dysfunction with macular involvement. This is another patient who has bifid subfoveal cavitation. Does this patient, and a similar history with poor acuity since childhood. So does this patient have KCNV2 disease? Nothing much to see in the fundi of any specificity. And when we look at the electrophysiology, this patient doesn't have a cone dystrophy. This patient has no detectable cone function whatsoever. We look at the red flash under dark adaptation, cone component is lacking, rod function preserved, and no cone function whatsoever. So this patient phenotypically has achromatopsia, but genetic screening was refused. The two main genes for achromatopsia are CNGA3 and CNGB3. This is a patient with CNGB3 mutation and has classical achromatopsia. On electrophysiology, normal rod function, bright flash, and no detectable cone function, including S-cone ERG, so this is complete achromatopsia or rod monochromacy. And yet the abnormality is that of a single foveal cavitation. This is another patient who has a single foveal cavitation, but with a different history. 8-month history of reduced visual acuity. Electrophysiology shows no generalized ERG abnormality, and indeed even the pattern ERGs are normal, suggesting that the abnormality really is very localized. And then when we do a multifocal ERG, we see in the central foveal hexagon very localized dysfunction, with the central response being smaller than its fellows. Back to the history, showed the patient was HIV positive and been indulging in poppers and has poppers maculopathy. And just to revert back to optic nerve disease, this is a 6-year-old with immune-mediated meningoencephalitis following COVID. The patient was noted by her father only to be able to read when holding things very close. Acuity was reduced. MRI showed no optic nerve involvement that was detectable and was referred to eye. There was nothing much in the anterior chambers, nothing much to see in the retina, but there was a suspicion over whether the left disc was slightly hyperemic. And when we look at the electrophysiology, there's a massive pattern VEP delay. Pattern ERGs to a 15-degree field, not so fantastic. The patient wasn't particularly cooperative, with a large field, beautiful P50, no N95. So this is indeed severe optic nerve disease with ganglion cell involvement, and ERGs, again, with skin electrodes, normal. So, and between January 22 and February 22, possible slight increase in disc power, but that's all. So imaging is very powerful. It can reveal unsuspected features, but it's often non-specific, and normal structure does not mean normal function. Electrophysiology reveals function. Occasionally it's diagnostic, but it always reveals the nature and severity of the disease, which may be unsuspected. It can direct mutational screening, and not shown here, can monitor efficacy or safety of treatment. And the most important take-home message is that optimal management needs both structure and function. Thank you very much for your attention.
Thank you so much, Graham, and what a perfect concluding line. So we have something here already in the audience for you. I can't quite see you yet, though. So there's a question. What general suggestions and organizational tips do you have for somebody who's starting up electrophysiology in a tertiary center?
That question could go on for the whole length of the webinar. Basically, first of all, the person who's going to be doing the interpretation needs to have subspecialty training and needs to familiarize themselves not only with the interpretation, but the ability to perform the tests. Because you're the person who's going to be responsible for training the technicians, so you've got to be able to do the technician's job better than the technician can, so you can teach the technicians. Because they will go, they will come, they may be female and have children and go off somewhere, they may be men and move on. You've got to teach the next technician, so you have to have those skills. You then have to decide what equipment to buy. You have to do normal controls, etc., etc. And the process goes on and on. But most of all, adequate training, subspecialty training, very great attention to detail, because electrophysiology is all about measuring very small signals, and you have to be very precise, very accurate, and skillful, and dedicated.
Thank you, Graham. So I think that sort of comes around to summing up the need for some international education and actual certificated education, I think is important. I have some specific questions which I wondered if I might just ask. Have you ever seen a recovery of a pattern ARG N95 in any disease? Oh, I'm sorry.
Not convincingly.
Okay. So do you think that's prognostically is very...
Well, when I say that, I mean, yes, you can, but only in the context of recovering P50 when N95 is reduced consequent upon P50. But in terms of reversible ganglion cell dysfunction, no, I don't think so. And yes, it is prognostic. For example, if you think about ethambutol toxicity, ethambutol is used in the treatment of tuberculosis, as you know, and can give you a toxicoptic neuropathy. If you stop the treatment while the patient still has a good and normal N95 component, then you've got a pretty good chance, or at least they have a chance of recovering visual acuity. It may take 6 or 7 months, perhaps even longer. But if the N95 has already gone, the chances of getting good recovery following cessation of the ethambutol is slim.
Okay, thank you. I wondered if I may indulge by asking maybe the other panelists as well. How can you differentiate between choroideremia and gyrate atrophy in the early stages, both structurally and functionally, if you have a... Well, because we often see very end stage choroideremia pictures, I think, as Isabel, you very beautifully showed. And I say this because recently we just had a wee lad who we saw, who had most, you could almost see a scalloping in the fundus autofluorescence. And I was just curious of how you might distinguish the two. So I'd be very grateful for your opinions.
I don't know, maybe Bart also can discuss on that. Obviously, if it's a girl, you know, because choroideremia is X-linked. So, but the few gyrate atrophy that I have seen, they usually have high myopia. They usually tend to have phoboschisis and early onset cataract. And I do think they have some more pigment migration than in choroideremia. So I think the atrophy is a bit distinct than what you see in choroideremia. But maybe Bart, you have more experience than me on that.
I agree, and then the lesions in gyrate may be just a touch more peripheral, and then moving concentrically towards the center, where choroideremia shows abnormalities in the general fundus, also in the area around the posterior pole. That's something you won't see necessarily in all cases with gyrate, although I've seen cases with gyrate atrophy with a Pac-Man-like. I know that dates me, but a Pac-Man-like atrophy.
Right, we understand.
I'm sure the younger people online won't understand what Pac-Man is, but look it up. I mean, it'll be in the historic books, and some sort of an atrophy of the center can be seen.
I have another suggestion as well. Examine the mother.
By all means.
Because the mother of the choroideremia child will almost certainly have an abnormal fundus, often a salt and pepper type. If you do autofluorescence, you may see radial changes, which are quite characteristic. So examine.
Although it doesn't, I fully agree, Graham, and sorry to jump in there in the interest of time. I have had it twice that a choroideremia patient, when I looked at, eventually proven through molecular screening, had choroideremia due to a novel mutation, and so the mother was normal. So a normal mother's fundus doesn't exclude it, but an abnormal does obviously help.
Yep.
Sure.
De novo, yeah. Or you examine the daughter if there's one daughter.
Yeah.
Well, thank you, everyone. Could I? Do we have time for one more that I could pick your brains whilst here? Because the foveal hyperfundus autofluorescence, the little white dots that you can get early on, we're seeing a little bit more frequently in ciliopathies as well as achromatopsia. I was wondering, is it foveal cone redundancy that allows you to have these cones under stress, but no functional consequence? I wondered if you had any views or ideas about that.
You mean hyperautofluorescence? Is that what you're saying?
Yes, where you have a white dot hyperfundus autofluorescence right at the fovea.
In the achromatopsia patient.
In the achromatopsia patients, but we've also seen it in some ciliopathies and also like CLN2, for example. Yet it doesn't appear yet to have an identifiable, there's no widespread cone dystrophy. There's no maculopathy that you can actually detect functionally. I was just curious as to why this can herald something or what it might mean.
It might just be the sign that you can see prior to atrophy of the central area at the level of outer retina, being the loss of the central cones, which in quite a number of cases of achromatopsia you can see later on. And so the interesting thing is that if you look at dog models of achromatopsia, they seem to have a cone, functional cone response very early on in life, immediately postnatally. Some of the dogs described with eventually achromatopsia, 2 mutations in CNGB3 or A3, you see a cone response, and then it immediately dies off in the weeks after. And so this has made me think, and this is really left field thinking. Don't take this as certain. It's my interpretation. Could achromatopsia be like a very early cone dysfunction that initially after birth has some function remaining and then it crashes? Whether the hyperautofluorescence signal in the central fovea indicates a predecessor of what is eventually what you can see on OCT in some of the patients, being an absence of the photoreceptors or at least a paucity of thereof. I would assume that, but I'd love to have Isabel's input.
I'm not
sorry.
sure we actually have time for that, I'm sorry, because I think according to the timing that we've come to the end. But
we've come to the end already a couple of times, I think 10, 14 minutes now, so we can get it, we can carry on. We can just have her answer and then
just very briefly, actually, don't forget that the outer retina is kind of masking the autofluorescence of the RPE, and it's in these defects, that you can get in some achromatopsia. It could as well be a window defect because there's no outer segments, and then you can see through the natural hyperautofluorescence. That may be some hint.
We've just been given an extra 2 minutes.
Excellent.
But it is strange to see in achromatopsia some of these people later on having no outer retina or outer retinal cells representing the cones. And the interesting bit is from the early results from the gene therapy trials is that you don't really get like spectacular results, at least. Now, obviously, there's the whole question of amblyopia and so on and so on. So that's going to go on for more than 2 minutes. So we'll stop there.
Well, if I may, I will ask you one question. Isabel, Bart, both can answer within a minute. Where do you think we're going to get the funding from for the necessary gene testing, which is going to be indicated in most inherited disease clinics? Certainly, I work in Singapore. People don't get it for nothing. It's very expensive and it's a challenge.
Isa?
So it's very quickly, I would say we are lucky currently in France because we have 2 national platforms supported by the healthcare, but I don't know how long it will last.
I personally believe that if the world were to move to systems like the European National Health Services, that would be really a good thing. Now, I'm under no illusion that that will happen. But I do believe that if people were to pay generally as a population to add money into a pot that could pay for such screening, that would be a really, really positive thing for the population. I think it's a shame to have to pay, like in Singapore, for molecular screening using grant money. But then again, you pay less taxes. So. But if there's money for military, there should be money for genetic screening.
I don't think we should be mentioning military at the moment.
Yes. But
yeah.
on the other side, you know, Graham, the technology is improving and the prices are dropping. So at some point, it may be less expensive for this genetic testing.
Yeah, but they're still very difficult to interpret the results. Okay, I think we need to wrap up now. So can I thank all the presenters very much for a splendid job, for sharing expertise, for sharing your time, and for committing yourselves to SOE. I think SOE should be pretty happy, and I hope the audience were pretty happy. There will apparently be a survey at the end of the webinar for the participants. If you could please take the time to complete this, it will be appreciated. And thank everybody for coming, and particularly nowadays with what's going on in the East. Stay healthy, stay well, and be nice to everybody.
Bye-bye.
Take care.
Bye-bye.
Bye-bye.